welcome. Thank you so much for joining us for this presentation. I am going to go ahead and start our talk. All right, wonderful. Happy Saturday to everyone. We're really looking forward to giving this talk entitled PI3 kinase, AKT, mTOR pathway inhibitors in the treatment of hormone receptor positive, HER2 negative breast cancer. I'm Ariel Medford. I'm an attending physician and oncologist at the Mass General Cancer Center and an instructor at Harvard Medical School. I'm here with my wonderful colleague, Dr. Giordano, an assistant professor at Harvard Medical School and medical oncologist at the Dana-Farber Cancer Institute. This presentation is supported by an independent educational grant from AstraZeneca Pharmaceuticals. And here I'll leave this on for specific physician and nursing credit, as well as physician assistant and associate credits. And I'll note that in order to receive your CME or CT certificate, please make sure that you view the entire webinar, and you will have to complete a brief evaluation, and please note that that will be due by March 20th, 2026. So I'll put up some disclosures of unlabeled use, as well as an overall disclaimer prior to our talk for you to peruse. And then this is our planner and speaker disclosure policy. And here are our disclosures. All right, so our learning objectives this morning. So 1, we will describe the PI3 kinase AKT mTOR pathway and the genomic profiling of ESR1, PIK3CA, AKT1, and PTEN in hormone receptor positive, HER2 negative metastatic breast cancer. We will review the current and emerging evidence supporting the use of the PI3 kinase AKT mTOR pathway inhibitors in the treatment of hormone receptor positive, HER2 negative metastatic breast cancer. And we will assess the adverse events in the management of hormone receptor positive, HER2 negative metastatic breast cancer treated with these pathway inhibitors. This is an overview of our agenda. So I will start our conversation with a pre and post test poll, and then a talk on the overview of the pathway and the genomic profiling of ESR1, PIK3CA, AKT1, and PTEN. And then Dr. Giordano will have a pre and post poll as well and discuss the current and emerging evidence supporting the use of these pathway inhibitors in the treatment of this cancer, as well as the management of adverse events. We will then have a 15-minute panel discussion to close the morning. So I will start. So I'll start with a pre-test clinical vignette. So this is a 62-year-old woman who was previously treated for a localized grade 3 T2N0 estrogen receptor positive HER2 negative breast cancer with lumpectomy, radiation, and adjuvant aromatase inhibitor and ribociclib. 6 months after she completed the ribociclib, she underwent scans which were indicated for an unintentional weight loss and was found to have numerous hepatic lesions, biopsy of which showed that this was a recurrent, now metastatic ER-positive HER2 negative breast cancer. Her labs showed normal organ function. What is the next step in care? 1, move immediately to fulvestrant. B, move immediately to fulvestrant with abemaciclib. C, send next generation sequencing testing, tissue and/or liquid biopsy. Or D, start cytotoxic chemotherapy. I'll give you time to put in your answers and we'll briefly look at those before going into the talk. Wonderful. So it looks about 63% of patients would send NGS testing. A quarter of participants would move to fulvestrant and abemaciclib, and 13% will move immediately to fulvestrant. Excellent. All right, so we will jump into the talk and then we'll repeat this at the end of the talk. So my talk, as mentioned, will be going over the PI3 kinase AKT mTOR pathway and the genomic profiling of ESR1, PIK3CA, AKT1, and PTEN in the hormone receptor positive HER2 negative breast cancer. So these are the objectives. We'll describe the signaling pathway and its role in breast cancer therapy. We will discuss ER signaling, estrogen receptor signaling, and the role of ESR1 mutations in therapy selection for the subtype of breast cancer. We'll describe the role of comprehensive genomic profiling, abbreviated CGP, in breast cancer. We'll discuss the tools we use for CGP in breast cancer, and then have a nod to some future applications and some novel and exciting clinical trials underway. So to start, let's describe the PI3 kinase AKT and mTOR signaling pathway. So broadly speaking, if we think about this as the cell surface, receptor tyrosine kinase inhibitors trigger PI3 kinase, which triggers the conversion of PIP2 to PIP3. PIP3 then leads to the activation of AKT downstream, which subsequently leads to mTOR signaling, which ultimately leads to tumor growth and survival. PTEN inactivates PIK3 and so negatively impacts the signaling pathway, whereas activating mutations of PI3 kinase and AKT lead to activation of this pathway. And so Dr. Giordano is going to talk about the evidence behind the treatment pathways, but this is a nice setup for us to think about what these standard of care therapies are. So the PI3 kinase pathway, if patients have PIK3CA mutations, they qualify for PI3 kinase inhibitors, and these are the two currently FDA-approved therapies, Alpelisib and Abemaciclib. And then the AKT inhibitors and the currently approved therapy is Capivasertib is actually approved for patients with mutations in PIK3CA, AKT, and PTEN. So this is the overall landscape of the currently approved targeted therapies for the signaling pathway. And then similarly, in talking about the overall signaling pathway, we also want to talk about the estrogen receptor signaling itself and specifically the role of ESR1 mutations. So broadly speaking, thinking about anti-estrogens and their mechanisms of action in breast cancer. So aromatase inhibitors are a standard of care therapy in breast cancer, and they function by blocking the conversion of circulating androgens into estrogens. Estrogen works as a ligand for the estrogen receptor, and by binding the estrogen receptor, signals it to lead to gene transcription and subsequently cancer cell growth. And so aromatase inhibitors function by blocking production of the ligand, and that'll be important as we talk about ESR1 mutations. Selective estrogen receptor modulators variably modify the activity of the estrogen receptor. These are approved in early breast cancer, so this would be like tamoxifen. And then selective estrogen receptor degraders, the currently approved degraders we'll talk about include fulvestrant and elacestrant. These function by binding the estrogen receptor and leading to its overall degradation. So both of these function downstream of the aromatase inhibitor. And then novel therapies that are not yet approved, but are certainly making waves within the estrogen receptor signaling and prevention pathways are PROTAC. So those are proteolysis targeting chimeric therapies. These work by using E3 ubiquitin ligase to degrade the estrogen receptor. Serans are complete estrogen receptor antagonists. So these fully block the activity of estrogen receptor. And then SERCAs or covalent antagonists similarly permanently block the signaling of the estrogen receptor. So the first three, the AIs, SERMs, and SERDs, are currently FDA approved, and the other three therapies described are currently under study. So specifically thinking about the aromatase inhibitor action and ESR1 mutations. So ESR1 mutations are activating mutations that lead to constitutive ER signaling. In other words, the estrogen receptor does not need the estrogen ligand to bind to it to tell cells to grow. For this reason, this is why ESR1 mutations lead to resistance to aromatase inhibitors, because aromatase inhibitors work upstream of the estrogen receptor. And so if you have an activating mutation, it doesn't matter if you're lowering the levels of the ligand anymore, because unfortunately now the receptor itself is signaling independent of estrogen. So that's the rationale for why these mutations lead to resistance to aromatase inhibitors specifically. When we see these, this is often a discussion about other approved standards of care, and the selective estrogen receptor degrader, as you can see, works downstream. So that's blocking the actual receptor that is now constitutively active, and that's the rationale for using SERDs in the setting of an activating ESR1 mutation. I'll say that ESR1 mutations are almost always acquired. So in other words, if you sequence the primary tumor when it's developed and a patient has not been exposed to aromatase inhibitors, you will not see ESR1 mutations. These are acquired mutations that arise in the setting of selective pressure from aromatase inhibitors. The Emerald trial was a practice-changing clinical trial that evaluated in postmenopausal women and men with advanced breast cancer who had already experienced progression on at least one line of endocrine therapy and at least one combination with the first-line CDK4/6 inhibitor. The groups were stratified by ESR1 mutation status. We'll discuss the biologic rationale for that. And they were randomized 1-to-1 to receive elacestrant, which is an oral SERD, and compared to, at the time, the approved endocrine therapies in the metastatic setting, which were the intramuscular SERD fulvestrant, as well as the 3 approved aromatase inhibitors, anastrozole, letrozole, and exemestane. The primary endpoint was progression-free survival in all patients, as well as in specifically the ESR1 mutated population. We'll discuss why that was significant. So these were the results of the Emerald trial that led to the approval of elacestrant. And I always think this is a really compelling graph to look at because if you look at both groups, all patients and the patients with ESR1 mutations, in both groups, there was an immediate drop-off with a number of patients that unfortunately experienced progression quite early. And the rationale there is these patients appear to have disease that is now resistant to blockade of the endocrine pathway. And why would that be? So if we go back and think about the signaling pathway here, we're talking about ESR1 mutations leading to signaling, but there are other ways that cancer cells can develop resistance to endocrine therapy. And downstream signaling of ESR1 is an ER-dependent pathway, but there are also non-ER-dependent growth mechanisms that can serve as bypass pathways in this specific population. So for that reason, I always tell patients that, well, one, both groups had populations that had disease with inherent SERD resistance, but I always explain that the elacestrant is not specifically targeting ESR1 mutations. It's targeting the estrogen receptor. If you have an ESR1 mutation, it is more likely that that cancer is still relying on estrogen receptor signaling and so is more likely to benefit from continued blockade of the estrogen receptor pathway. But it's an increased likelihood. This is not a direct measurement of continued ER dependence. And so that's where I think there's a great rationale for continued studies for biomarkers of continued dependence on the estrogen receptor pathway. And so now, how does comprehensive genomic profiling play into this overall landscape? So if we think broadly, I'm going to give a big overview of, really an incredible increased cadence of approved therapies in hormone receptor positive HER2 negative breast cancer. And that'll also lay a nice groundwork for Dr. Giordano to talk through the rationale and the clinical trials that have led to these exciting approvals. So the first therapy was tamoxifen, approved back in the 70s. And that, again, is a selective estrogen receptor modulator. So that used to be the only endocrine targeted therapy approved in this breast cancer population. And then it wasn't until 1995, so just short of 20 years later, that anastrozole, the first aromatase inhibitor, was developed. This was quickly followed by letrozole and exemestane. So those are the 3 approved aromatase inhibitors. Subsequently, fulvestrant, so again, that's an intramuscular selective estrogen receptor degrader, was approved. And then a decade later, Everolimus and exemestane were approved. And Everolimus is an mTOR inhibitor, but it's not a biomarker-specific therapy. In other words, this is not something that needs a matched biomarker for indications for patients with this breast cancer subtype. And then several years later was when CDK4/6 inhibitors became a standard of care. So letrozole and palbociclib, followed a couple years later by letrozole and ribociclib, another CDK4/6 inhibitor. And that same year, Abemaciclib was also approved, all for first-line therapy in combination with an aromatase inhibitor, not exclusive to letrozole, so that also can include anastrozole or exemestane in metastatic breast cancer. And then when we think about the genomic profiling space, this is when things really start taking off because in 2019, the SOLAR-1 trial, which Dr. Giordano will describe, was led to the approval of Alpelisib in combination with fulvestrant for PIK3CA mutated breast cancer. 4 years later, that was when the Emerald trial led to the approval of elacestrant, and that approval was only for patients with ESR1 mutations. Again, that surrogate marker of continued dependence on the estrogen receptor signaling pathway. And then that same year, Capivasertib was approved for any mutations within that PI3 kinase signaling pathway, so PIK3CA, AKT, or PTEN. And then most recently, the INAVO 120 trial led to the approval of Alpelisib. So this was specifically for endocrine-resistant early metastatic recurrence, and it's a triplet combination. So this one was approved for in combination with Palbociclib and fulvestrant. The stars here are indicating biomarker-specific indications. So only if you had one of these biomarkers in parentheses would a patient qualify for these specific therapies. And notice how these are all getting clustered in this new landscape of genomic profiling and genomic-guided therapy. And so if we think about the kinetics of circulating tumor DNA, I think that really tells us a lot about how this is incorporating into the landscape of our breast cancer therapies. So all cells shed DNA into the bloodstream. That's called cell-free DNA. And when that DNA is shed specifically by cancer cells, that's circulating tumor DNA. And it's something that we can now measure in the bloodstream, which is incredibly helpful for tracking for acquired variants, clonal evolution, et cetera. ctDNA has a half-life of around 2 hours, and so it really is a nice real-time measurement, not just of tumor fraction, but actual mutational profiles and scavenging for acquired mutations. So typically, after a patient undergoes curative intent therapy, ctDNA levels should drop to 0. Again, I said the half-life is quite short. Unfortunately, we know that around a third of patients may experience recurrence. And at that time, it is crucial that you do genomic profiling at the time of recurrence. That's to look for PIK3CA mutations, which are typically truncal. So about 30 to 40% of breast cancers will have a PIK3CA mutation at the time of development. This can be with tissue and or liquid biopsy, and this should be done before deciding on the treatment selection to make sure you are giving patients their most targeted therapies. I usually say, tissue biopsies are pretty typical at this time point because we do want to confirm receptor status, make sure this has not undergone a subtype switch, say to a triple negative breast cancer. But the liquid biopsy also has the advantage that it allows for us to sample from all sites of disease. So it accounts for intra and intertumoral heterogeneity to really look for clonal evolution in the setting of a new metastatic diagnosis. And then once that treatment is effective, typically ctDNA levels will drop, but unfortunately, we know in the metastatic setting, typically patients' cancers will develop resistance eventually. And at the time of progression, that's the time that you really want to do more genomic profiling to look for acquired mutations. Remember, I said ESR1 mutations will not be present in the primary tumor, but they are the most common acquired mutation. And so notice I have liquid biopsy listed before tissue biopsy in the subsequent treatment selection. And we'll discuss some guidelines that explain that. So one is somatic genomic testing in general in patients with metastatic advanced cancer. So this is independent of breast cancer. So this was an ASCO provisional clinical opinion that was issued back in 2022 that was effectively saying that if patients had metastatic or advanced cancer, they should be undergoing genomic sequencing to look if there is any biomarker that has approval in the use or exclusion of therapies for their specific disease. And then multi-gene panel-based assays should be used if more than one biomarker-linked therapy is approved. And remember, I just talked through multiple biomarkers that have approved therapies. We've talked about 4, PIK3CA, AKT, PTEN, and ESR1. And that is exclusively just in that breast cancer subtype. But the other important piece, which is a whole other talk we won't go into the details of, but something for us to think about, is we also have tissue agnostic approvals. So approvals for biomarker selected therapy that does not have a cancer type specific. So at the time of this opinion, NTRK fusions were a classic example. And in fact, around this year, we published a case report of a patient who had what seemed to be very refractory disease. And then we were able to develop and discover an NTRK fusion, treat it with targeted therapy, and the patient had an incredible clinical response. And then since this time, only more tissue agnostic therapies have been approved. And so I would argue that this really does say that if a patient is otherwise able to tolerate a targeted therapy, this really is an argument for multi-gene testing in all advanced solid tumors. And then breast cancer specifically. So ESR1 mutations, I will keep saying these are acquired mutations. So if you send a liquid biopsy test and it is negative, every single time a patient has progression, that a patient's cancer experiences progression, we should be sending to look for these acquired mutations because it helps us understand what's happening with resistance mechanisms in the cancer, and it also qualifies patients for targeted therapy like elacestrant. And so this opinion was saying that for all patients at the time of progression, they should be getting ESR1 mutation testing. And the interesting thing I'll highlight is that blood-based testing is preferred. Again, I mentioned this is more sensitive because it is accounting for all of the metastatic sites within the body. So intra and intertumoral heterogeneity. The blood's effectively a repository for us to look for these mutations. The other thing I'll say is that this type of breast cancer often has bone-only disease, and biopsy of bone can be pretty tricky for genomic profiling because when we decalcify the bone, then there's more of a challenge in actually doing the genomic profiling. And so blood-based is preferred, which is why I advise for any patient with this breast cancer subtype at the time of progression, sending a liquid biopsy. And similarly, as I mentioned, PIK3CA, that tends to be truncal, but currently we're seeing that not all patients are undergoing this testing at the time of metastatic diagnosis. And so if it has not been sent, these patients need to be evaluated for PIK3CA mutations again, because it qualifies them for more targeted therapies. As I mentioned, even if you're sending testing and you keep seeing there's no ESR1 mutation, every time a patient experiences progression, they should be offered this testing again because this is an emergent mutation. And so what are the tools that we use? So I'll start with the liquid biopsy because there are quite a few. And I will say they've been expanding as well. So the FoundationOne Liquid assay was approved as a companion diagnostic for PIK3CA mutations. The Garden 360 assay was the companion diagnostic in the Emerald trial for ESR1 mutations. And then subsequently, we have a number of other assays, and here are some examples. The Garden Infinity platform is also the Guardant platform. It's more methylation based, or has a methylation component, and now is assessing for over 700 genes as opposed to the original 74. And then Tempus and Caris as well have liquid biopsy assays that are assessing for hundreds of genomic variants. I mention this because obviously I'm mentioning just several biomarkers today that have approved therapies, but the reason we knew to look for those approved therapies is because we were mapping the clonal landscape and the genomic landscape of patients throughout the natural history of breast cancer. And so you can imagine that with these types of testing, we're also generating a lot of genomic data to help us understand cancer evolution and develop good future therapies in our patient populations. And then similarly, tissue-based assays, there are a number of tissue-based assays now. You'll notice some similar players like Foundation, Caris, Tempus, Garden 360. There's also the Boston Gene Tumor Portrait, OncoExtra, and NeoGenomics. In some of these cases with the liquid biopsy, we were talking about hybrid capture, so a gene panel where they were specifically looking for a known set of mutations within the liquid biopsy. We're seeing with a lot of the tissue-based assays, whole exome sequencing-based technology, whole transcriptome sequencing. And really, this is to say that one, there are a number of assays that are available to our patients, and also we're generating so much data. And my hope is from a translational lens as well to really understand, we really should be studying this data as it's developing so that we can understand how best to tailor future therapies for our patients. And so last, with future applications, it feels like I should mention one of the plenary sessions that was presented at ASCO this past year, which was SERENA-6, which was a really novel approach to how we design clinical trials. The standard of care is if a patient's having progression radiographically, so on scans, then we change therapy. And this was looking, well, if we know that ESR1 mutations are leading to resistance to aromatase inhibitors, what if we monitor for ESR1 mutations early and then have a specific therapy switch at the time of molecular evidence of resistance rather than radiographic? And so this was for patients with hormone receptor positive, HER2 negative advanced breast cancer who are on first-line therapy, so an aromatase inhibitor with a CDK4/6 inhibitor. And they underwent ESR1 testing every 2 to 3 months. So again, not prompted by progression. And then we're randomized to receive camizestrant, so another oral SERD, and then continuing the CDK4/6 inhibitor versus continuing the aromatase inhibitor they were on, which is currently the standard of care, even if you detect an ESR1 mutation. And so the primary endpoints were disease progression, death, or unacceptable toxicity, or otherwise patient withdrawal. And then there were important stratifications here for other high-risk disease features. And so whether or not there was visceral disease, whether or not the ESR1 mutation was detected at the first or later test. I think that's a particularly important piece here because over half of the patients had detectable ESR1 mutations at first testing, which means they probably, or many of those may have developed earlier, and so would have potentially had an earlier switch, how long they had been on the CDK4/6 inhibitor, and then the identity of the CDK4/6 inhibitor. And then here you can see the primary endpoint was the PFS, and then secondary endpoint, PFS2. That's an important endpoint of discussion because the question is certainly if you're doing an early switch, do you then sacrifice the efficacy of the second-line therapy? And so we're looking forward to the follow-up data of the PFS2 and the overall survival. And then interestingly, we were seeing that at least with that first PFS, the median progression-free survival was quite a bit longer in the camizestrant group, so 16 versus 9.2 months. And then interestingly, they used another metric called a median time to deterioration, which was 21 months in the camizestrant group and 6.4 months in the patients that continued an aromatase inhibitor. So really provocative findings. This has not led to practice changes, but I think really talks about what future applications of comprehensive genomic profiling in clinical studies may look like. And I look forward to seeing other molecularly guided clinical trials to challenge and ask questions about how we can further improve patient care. So broadly speaking, how does this whole landscape then fold into our approach to metastatic breast cancer care? So the first-line therapy right now is an endocrine therapy in combination with a CDK4/6 inhibitor. Today, the overall survival data is linked to ribociclib and abemaciclib. So those are typically our first-line CDK4/6 inhibitors. The exception is if a patient has a PIK3CA mutation and have been found to have endocrine refractory disease. That's an approval for inavolisib, and the INAVO120 trial was looking at triplet therapy with fulvestrant and palbociclib. Second line, in the absence of a targeted therapy, patients can switch to a SERD like fulvestrant with or without an additional CDK4/6 inhibitor. But if they have a targetable mutation, which you can see in all of the parentheses, these are all biomarker-driven therapies. Alpelisib is for PIK3CA mutations, Capivasertib for anything within the pathway, elacestrant for ESR1 mutations, and not going into the germline variants, but olaparib and the PARP inhibitors for patients with germline BRCA mutations. And then third line is when we move into less targeted anti-estrogens with Everolimus, as well as the antibody drug conjugates and chemotherapy. The main piece I'll highlight here is that for next generation sequencing testing, patients should all undergo biopsy and/or ctDNA testing at baseline, and every patient who's experiencing progression, a discussion should be had for them to have ctDNA genomic sequencing. So thank you so much for your time, and I will circle back to the same clinical vignette. So again, this is a 62-year-old woman who was treated for a localized grade 3 T2N0 estrogen receptor positive HER2 negative breast cancer. She had local therapy and was on adjuvant aromatase inhibitor and ribociclib. 6 months after completing the ribociclib, she developed unintentional weight loss and was scanned and discovered multiple liver metastases, and biopsy confirmed this was metastatic ER-positive HER2 negative disease. She had normal organ function. So what is the next step in care? And so here, I know, yes, we'll pull up again and then look forward to discussing the answer. Beautiful. So exactly. So as we're moving, all patients, as mentioned at this time, should first have NGS testing. This patient would qualify for a targeted therapy if they had a PIK3CA mutation. And targetable therapies are important to underline our subsequent therapies as well. And again, with the patient being on an aromatase inhibitor, then they're at risk of having developed an ESR1 mutation as well. So excellent. Thank you so much for your time. I will stop sharing, and Dr. Giordano is going to take over.
So we're going to start with a clinical vignette as well. This is a 72-year-old postmenopausal woman with a long-standing history of hormone receptor positive breast cancer that was early breast cancer diagnosed a long time ago in 1995 and has since experienced multiple local recurrence, including adjuvant chemotherapy with TCNAI and metastatic progression then to the bone in 2019. This is her the clinical treatment that she received. I actually saw this patient last week from 19 to 20, first line with fulvestrant and Palbociclib. Later switch to Abemaciclib due to concern of immunosuppression and diarrhea. That was actually right around the COVID pandemic, and that's why the switch was made. June 21, after clinical progression, she enrolled on a clinical trial with an oral SERD that Dr. Medford touched in her talk as well, because had an ESR1 mutation. In August of 2021, fulvestrant and Alpelisib, so a PIK3CA inhibitor, was selected because a CT DNA detected a PIK3CA mutation. And in February of 2022, after about 6 months, she progressed and then received capecitabine. In November of 2023, she was enrolled after progression on CAPE on a clinical trial with a CDK4 selective in combination with fulvestrant. So like in a post-Monarch style, we recycle a cell cycle agent here. And then a progression of disease in November of 2024, bone only again. Again, a ctDNA was redrawn here that show a rising pathogenic PIK3CA mutation, and what treatment you would recommend in this case. So we have A, exemestane single agent endocrine therapy, B, fulvestrant plus capivasertib, C, dose-dense AC, D, CMF chemotherapy. Okay, perfect. So we have the majority, they voted 64% with fulvestrant capivasertib. So we are going to see in this next presentation the current and emerging evidence supporting the use of PIK3CA, AKT, mTOR pathway inhibitors in the treatment of hormone receptor positive, HER2 negative metastatic breast cancer, and the management of adverse events. So as you now well known after Dr. Medford lecture, PIK3CA is involved in the production of PIP3, which activates then AKT and cell proliferation, and is very frequently dysregulated in cancer, and specifically in breast cancer. We have had tons of approval for targeted agent and endocrine therapy. And you can see in yellow in these slides that we all use from Dr. Seb Wonder, there are currently 4 drugs that are FDA approved for the target, the PIK3CA pathway. And we are going to take a look at this clinical trial that led to the approval. But as we were seeing, PIK3CA, AKT, and PTEN are really frequently altered in hormone receptor positive metastatic breast cancer. And as you now well known, is also they are strictly related to mechanism of resistance of endocrine therapy, and also CDK4/6 inhibitor, as you will see. So 41% in a prospective population of 1,500 patients have a PIK3CA mutation, while 9 and 7% also have a PTEN and AKT1 mutation. And you can hear that in other prospective or retrospective clinical trial in centers in the Netherlands, you can see that this mutation try to increase in frequency as you move from the primary to the metastatic site, and from like when patients receive treatment with endocrine therapy. PIK3CA mutation are also an independent indicator of poor prognosis. So patients that carry a mutation on the pathway are usually associated with a poor response to therapy and a worse overall prognosis in breast cancer. So we go back in 2012 when the Bolero-2 was a proof of concept study with an mTOR inhibition for ER-positive metastatic breast cancer, so exemestane plus Everolimus, that improves progression-free survival after non-steroidal aromatase inhibitor. Everolimus is drug that target the mTOR, that is downstream PI3 kinase and AKT, and the trial that randomized patients to receive Everolimus plus exemestane versus placebo plus exemestane showed an improvement of the progression-free survival and in both local assessment or investigator assessment with no overall survival benefit. Since then, we have had several other clinical trials that have shown the clinical activity of Everolimus in combination with fulvestrant. And now we use this drug in combination with exemestane or sometimes with fulvestrant in the second or fourth line for hormone receptor breast cancer for patients that progress of endocrine therapy agnostic from the presence or not of a PIK3CA pathway mutation. What we have seen, though, with starting to see with the use of Everolimus and from the toxicity table of HER2, that there was a pretty higher discontinuation rate compared to placebo. There was about 20%. And the majority of those side effects were characterized by the presence of like stomatitis, fatigue, dyspnea, anemia, hyperglycemia, and also pneumonitis. And I think that the side effect we struggled the most in clinic at that time was the oral mucositis and the presence of mouth sore with patients that were taking everolimus. And after the study that was following 2017, the SWISH study, we actually realized with the steroid mouthwash, usually we use a dexamethasone 0.5% mouthwash 4 times a day for prevention of the mucositis, we were able to reduce the incidence of these side effects dramatically and make the drug more tolerable. When we look at the pathway at that time, we also were trying to figure out to identify drugs that were more selective for the alpha isoform of PIK3CA, that is the one that is mainly involved in endocrine resistance and cancer proliferation. And then you will see drugs like Alpelisib, and following that Everolimus, they made to the clinical trial. So the SOLAR-1 study, it tested the combination of Alpelisib plus fulvestrant versus fulvestrant alone in patients that had previously progressed on a endocrine therapy, an aromatase inhibitor. And the study published in 2019 demonstrated that the combination of a PIK3CA alpha inhibitor with fulvestrant improved the progression-free survival in the second-line setting with an overall survival in favor of the combination, but not statistically significant. This led to approval of Alpelisib, and then we were followed by other clinical trials like the BILIVE study that had a similar population, but this time that received already a CDK4/6 inhibitor, because at that time you have also to remember that the CDK4/6 were approved, and now like every patient at that time and this time gets a first-line combination with a CDK4/6 inhibitor plus endocrine therapy. And the BILIVE study also demonstrated the median progression-free survival or overall survival were comparable to the original SOLAR-1, and Alpelisib in combination with endocrine therapy is a valid option even after CDK4/6 inhibitor. What were the challenges that we encountered in the SOLAR-1 study, in the BILIVE study, and also in clinic when we use Alpelisib? So here you can see that one of the major AE that highlighted here is hyperglycemia, with 33% having actually grade 3 hyperglycemia, 4% grade 4 hyperglycemia. This is a very important side effect and a very delicate side effect that patients have to deal when prescribed with Alpelisib. And then also we have rash that is present in about 10% of the patient as a grade 3 and 36% all grade. That also is a very peculiar of these class of inhibitors. You can see the stomatitis 25% all grade, and not reported here, but pneumonitis is also another side effects that is peculiar of these class of drugs. When we looked at the pathway, there was another effort to try to target something that was downstream of PI3 kinase. And here we started to see the clinical trial with Capivasertib, that is an AKT inhibitor, in the FACTION clinical trial that enroll patient with NGS testing to identify an AKT mutation or a PTEN alteration in addition to PIK3CA mutation, found that there was a progression-free survival of about 12.8 months and an overall survival of 40 months when Capivasertib, an AKT mutant inhibitor, was combined with endocrine therapy. And this led to the design of Capitello 291, that is a phase 3 trial of Capivasertib plus fulvestrant in AI-resistant hormone receptor positive HER2 negative metastatic breast cancer. So in the second line setting, randomization 1-to-1 to receive placebo fulvestrant or Capi fulvestrant. And I want to point out here that prior CDK4/6 inhibitor was allowed. The hemoglobin A1C limit for this drug was actually set to 8%. That was nice for investigators to see, since like the A1C cutoff was way lower in the clinical trial for Alpelisib and the PIK3CA alpha selective that we'll see later. So Capitello 291 enrolled the population of like 70% received a prior CDK4/6 inhibitor, 20% a prior chemotherapy agent. The progression-free survival by investigator and overall population was 7.2 months versus 3.6 months with fulvestrant alone, with an hazard ratio of 0.6. And similarly, in the AKT pathway alteration, we have a difference of 7.3 months versus 3.1 months. So those were the subgroup analysis that showed that the drug was effective in both the patient that received a prior exposure to CDK4/6 inhibitor, that of course is more representative of the population we have right now. It was also more effective in a patient with visceral metastasis, even though the PFS was shorter overall for this population, and was also independent from the chemo-naive versus chemo pre-treated population compared to placebo plus fulvestrant. When looked at the PFS2, so the second progression-free survival, this was also in favor of the population that received Capivasertib versus placebo, and the time to first subsequent chemotherapy also favored Capivasertib combination with fulvestrant compared to endocrine therapy alone. When we look at the side effects of Capivasertib, you can see that it's slightly different than alpha selective PIK3CA inhibitor, like such as Alpelisib. The diarrhea was actually more relevant with the Capivasertib, in addition to rash, but definitely we have seen less issue with hyperglycemia. And remember here we have also an 8% cutoff for A1C. But overall, the discontinuation of one or both treatment was just 13% versus 2.3%, and safety profile was pretty consistent with previously seen. We have now trials with other AKT inhibitors for unselected hormone receptor positive HER2 negative metastatic breast cancer, and there is another drug under investigation as well, that the Palbociclib in these three other clinical trials. There is a clinical trial ongoing now that is Capitello 292, that is actually trying to move the drug in the earlier phase. So this is for a endocrine resistant population that have not received prior CDK4/6 inhibitor in the metastatic setting. So as point this inclusion criteria, and no prior endocrine therapy in the metastatic setting. So this clinical trial, randomized 1-to-1, about 630 patients will be enrolled and are being enrolled fulvestrant plus a CDK4/6 inhibitor that initially only available is Palbociclib, in addition to placebo or in addition to Capivasertib, in a population that is not going to be selected for a PIK3CA mutation and never received, of course, a PIK3CA inhibitor. And the primary endpoint of this study are progression-free survival with a key secondary objective response rate and overall survival. There are, as Dr. Medford was discussing, for example, for the SERENA-6, there is a similar clinical trial design, but application more for a PIK3CA mutation and an anti-pathway drug. So you can see here in the FAME study that upon detection of high ctDNA, the patient would be stratified to add ipatosertib, so another AKT inhibitor, in addition to palbociclib fulvestrant. So this is another, we are going to see more and more of this study where are based on detection of some mutation. But when we step back in the lab, when we see that, look at the pathway and the interaction between the estrogen receptor, the PIK3CA pathway, and the cyclin D1 interaction with CDK4/6, we do know that a triplet inhibition, so a combination of endocrine therapy, anti-AKT, PIK3CA pathway, and CDK4/6 will actually synergize and try to reverse the resistance of those cancer cells. And here, a background for INAVO120, that is a phase 3 randomized double-blinded placebo-controlled study that enrolled patients with endocrine resistant and no prior therapy for advanced breast cancer. So patient must have a PIK3CA mutated, hormone receptor positive by central testing or ctDNA, no prior therapy for advanced breast cancer, and note here that the fasting glucose must be less than 126, and an A1C was like less than 6% in this inclusion criteria. So patients were randomized to receive Alpelisib, an alpha-selective PIK3CA inhibitor, plus Palbociclib, a CDK4/6, plus fulvestrant, versus Palbociclib, fulvestrant, or placebo. PFS was primary endpoint, and this last ASCO, we saw the updated PFS analysis. They show an hazard ratio of 0.42 in favor of the triplet. We saw actually also improvement overall survival with 34 months versus 27 months with an odds ratio of 0.67 and a p-value of 0.0190. Improvement objective response rate with a triplet 63% versus 28%, and duration of response way higher, 8 months median improvement compared to the doublet. So time to first subsequent chemotherapy also was in favor dramatically to the triplet of about 23 months different compared to the doublet. What about side effects? So the triplet actually had a total of there were 3.7% of grade 5 AE. AE leading to discontinuation of treatment of INAVO was about 6.8% versus only 0.6% for the doublet. And you can see that dose reduction for INAVO were 15% in the triplet here, and the Palbociclib dose reduction was 40 in the triplet versus 34.4 in the doublet. We have seen again stomatitis or mucosal inflammation with a 5.6% in the being grade 3/4. Hyperglycemia 6.8% grade 3 and 4, with 63% of any grade. Diarrhea, 3.7% grade 3 and 4, 52 all grade. Rash, majority were lower grades, and some also ocular toxicity, mainly dry eyes with the use of Alpelisib. Again, this is there are some limitation of Inavo 120. Specifically, for example, Palbociclib was the only CDK4/6 inhibitor using this assessment. There were very few patients that received adjuvant CDK4/6 inhibitor, and now we're seeing more and more of those patients treated with based on Monarchy and Natalie. And there were also a few Black and African American patient represented in this study. For the subgroup analysis of a secondary endpoint for the overall survival, there were still small events, and more updates are awaited. We are actually seeing more drug coming to the clinic. There is a clinical trial that is actually about to complete enrollment, and we are also gonna start to see some data, possibly the next ESMO, include Alpelisib, that is a drug that blocks several a molecule of the pathway from mTOR, AKT, and PI3K, has a clinical trial called Victoria-1, in which like second-line patient will receive either a combination of Alpelisib with fulvestrant or a triplet of Alpelisib, fulvestrant, and Palbociclib. Alpelisib is actually an IV formulation, and so it has the potential of reduce some of these side effects due to the a different type of metabolization, skipping, the oral and the liver, that potentially could reduce some of the side effects, including hyperglycemia, of course. Putting here all together in this table, we can see a toxicity summary of the 4 FDA-approved drugs of the pathway. Like quick recapitulation, like for example, Alpelisib and Inavolisib that are selective PI3K inhibitor are more, we are more prone to see like diarrhea, some rash, hyperglycemia. Capivasertib, diarrhea and rash are the majority of the limiting side effects, while for Everolimus was probably the stomatitis and some lower grade of hyperglycemia. There have been studies that have looked at the mitigation of the side effects that are really key, because those drugs are active as shown in this clinical trial, but the toxicity and the mitigation of the side effects is very important. It looks in this study where patient actually received metformin prophylaxis to prevent the hyperglycemia with Alpelisib. It showed that actually metformin was able to reduce the grade 3 event of hyperglycemia from 36.6% of the SOLAR-1 to 5.9% in the Metallica study. The mechanism for which like PI3K inhibitor induce hyperglycemia is an on-target effect, because PI3 kinase is very important in the regulation of glucose transporter, and so like blocking the pathway also it will induce like an increase of circulating glucose and insulin resistance, and that's why metformin seems to be the best upfront therapy for hyperglycemia induced by PI3K inhibitor. The next frontier we are seeing coming into clinical trial, phase 1, and also advancing progressively to phase 2 and 3, selective PI3K inhibitors. So those are molecules that try to block only the mutant portion of the PI3K enzyme, leaving the wild type not blocked, and so not causing some of the hyperglycemia we have seen with the pan-alpha selective. So we have seen, for example, some data from the LOXO 783, Relay 2608, and STX 478. Here are some examples. This is the structure of PI3K. with the kinase domain and the helical domain being the major target for those molecule. And since those are the where the majority of the mutation are found, the Relay 2608 is a first-in-class mutant-selective allosteric PI3K inhibitor, for which should avoid the hyperglycemia and the you can see the insulin resistance in this preclinical model. And this is a clinical trial that is undergoing in a phase 1 study, and also going to launch a randomized phase 3 study head-to-head with Capivasertib in the second line. And this one is the STX478 Scorpion allosteric PI3K inhibitor that was just recently acquired by Eli Lilly, and also will be advanced in a possible phase 3 registration study. And you can see that in the preclinical model and in some single agent from the phase 1 portion has shown to have activity in hormone receptor positive HER2 negative mutant breast cancer with some very, very low rate of hyperglycemia 3 and 4, grade 3 and 4, and less diarrhea as well. So what are the key messages for PI3K, AKT, mTOR pathway? You have to remember it's frequently altered in breast cancer and drives cell signaling, growth, and metabolism, and is actually conferred even a poor prognostic factor for those patients. It's mutated in about 40% of hormone receptor positive metastatic breast cancer, and it's an independent poor prognostic marker. Everolimus plus exemestane, agnostic. Alpelisib plus fulvestrant for PIK3CA mutant. Capivasertib plus fulvestrant for PIK3CA, AKT, and PTEN altered. And now Everolimus plus Palbociclib and fulvestrant in the first line endocrine resistant with the PIK3CA mutation are approved in hormone receptor positive metastatic breast cancer. And there are next generation mTOR inhibitor and mutant selective inhibitor that are still in early stage and advancing quickly in the later stage as well. The goal is to improve the therapeutic index of this drug with toxicity management, especially the hyperglycemia that is critically to identify early on and start those patients before they receive severe side effects. But diarrhea, skin rash, and mucositis are also critical for this class of drug. What are the future direction? Definitely, I think that the management of toxicity is key, but also we have seen the new mutant selective inhibitors that they're trying to improve the tox profile of those drugs. We definitely need to understand better the biomarkers for responsive resistance. For example, our PTEN mutation, the presence of PTEN mutation for patients that will receive a PIK3CA inhibitor important. And also the sequencing can be key as you, so for example, in my clinical vignette, I will comment about these after your next answer, but is there activity of Capivasertib after blocking PIK3CA? Because that's downstream of the pathway. What's the role of the triplet, and how do we put in the context of combination with CDK4/6 inhibitor and the advanced use of adjuvant CDK4/6 inhibitor? So Victoria 1 and Capital 292 are ongoing study. There is going to be also a Victoria 2 in the first line setting. What is the role of triplet in the endocrine sensitive population? So we will see that some of the new phase 3 study is also going to have some population that are endocrine sensitive, and with also what is the optimal partner for endocrine therapy partner for this targeted agent. We're using fulvestrant, but there are a lot of oral SERD and other class of estrogen blocker that may be useful in this situation. So thank you. This is again the vignette. This is a 72 years old postmenopausal woman with a long history of hormone receptor positive metastatic breast cancer, was early diagnosed in 95, metastatic in 2019, received first line fulvestrant palbociclib, then multiple clinical trial, including an oral SERD. She received fulvestrant Alpelisib as a third line because she was found to have a PIK3CA mutation. Then following progression, she received first-line chemotherapy with capecitabine. We switched back after progression to endocrine therapy. We're using a cell cycle blocker. And then in November of 2024, based on a ctDNA testing and a rising pathogenic PIK3CA mutation, what we recommended. So A, exemestane, B, fulvestrant capivasertib, C, dose-dense AC, and E, CMF. Please vote. The vote selection. So 91% perfect capivasertib fulvestrant. The patient came back actually last week. She is having an excellent response to the capivasertib fulvestrant and tolerated drug actually really well with sporadic rash. We have using very well controlled with cetirizine and now doing very well. I think it's time to open the question from the participant at this point. And remember also that for the CME, you have time up to March 20 of 26, so that's like 6 months. I think I can stop sharing here. It's a question about male breast cancer. I think early diagnosis, I believe this can contribute to improving detection and outcomes since the area is often overlooked compared to female breast cancer. Regarding male breast cancer, I think it's very difficult to infer about like clinical trial and new drugs, because it's a rare subtype. The message that we actually have a dedicated group here in Boston that looked at male breast cancer, and there are current clinical trial that actually enrolled and trying to understand the hormone, specifically endocrine therapy for male breast cancer. It is important to advocate to the regulatory agency like FDA and the drug company and make sure that male individual with breast cancer are included in clinical trial. But at this point, we'll say that we do use this class of drugs, so PIK3CA inhibitor in male breast cancer with pathway mutation. That's a very great point.
Yeah, and I think, just thinking about kind of with the landscape of what we've discussed today and kind of what the future holds, I think that's the other thing to really keep in mind is that while we're talking about areas that are under active study, we're generating so much data. And so I would say, especially in the space of, our biomarker analyses and all of this data, I think this is a real argument too for after these clinical trials, also getting really robust real world data and recognizing that, the priority is the patient in front of you, and patient data is so helpful for also shaping the future landscape. And so, yeah, I think kind of opportunities for the future, the way these trials are being designed, especially these molecularly guided trials, I see this being the future and really trying to really enhance personalized breast oncology across the board.
Ariel, do you use like a prophylaxis strategy when starting one of the drug that targets the PIK3CA pathway? For example, like in the Metallica study, they use like metformin even before starting the Alpelisib, or for Capivasertib, sometimes what I do is to start accredited
Mhm.
and even sometimes Imodium before starting the drug itself.
No, it's a great question, and I think so important when we think about the toxicity is I will say that, now obviously in endocrine refractory we have an Alpelisib, but even prior to that, I felt very strongly about looking for PIK3CA mutations at first metastatic diagnosis because of the diabetes issue, and diabetes takes a while to get under control, and so, I would joke with my patients, but not really a joke, that I was a kind of rudimentary PCP as well, because if I saw diabetes and a PIK3CA mutation, then, starting metformin, oftentimes years before it's even going to be a discussion of them going on a PIK3CA, PI3 kinase inhibitor. And I agree with you. I think the prophylactic approach, I think Imodium, always letting patients know that's really key to hold on to for some of these other studies where, stomatitis is more at risk, prophylactic mouth rinses, really kind of thinking ahead, because the best therapy is also the therapy that patients can tolerate. And so I fully agree with you on just lining up prophylactic strategies as well and
Yeah, I
prevent.
think I agree, I totally agree. I think it's very important to work, for example, with endocrinology or some of the other team to help mitigating the side effects, because um, it clearly from the clinical outcome, we have seen PFS data, overall survival data in favor of the use of uh, PIK3CA inhibitor and pathway inhibitor. So the strategy mitigation for side effects is key, and keeping the patient on the drug is key as well. Ariel, is there anything else that you want to add?
No, I think I'm glad that everyone was able to join us this morning, and I think this was a really productive conversation, just thinking about just the immense progress that has been made and that continues to be, pushing the frontiers to improving breast cancer patient care. So thank you, Dr. Giordano. Thank you everyone for joining us, and hoping to keep improving care.
Great. I think we can close our webinar right now. And it was really nice to uh, co-chair this with you, Ariel. And thank you everybody for joining.